Okay. All right, okay, I'll get started then. Thank you both for joining. So this will be a dermatology tutorial. I'll be doing the first half and Amar will be doing the second half. And this is a list of the things that we're going to cover. We're actually going to touch on all the core conditions apart from burns and some benign lesions, but that you can read about in your own time. So we'll start off with this question. 15-year-old male, acne, started with a topical retinoid and antibiotic, but it's not been of much benefit. What would be the most appropriate next step? Any ideas? So I can just quickly go through it. So it's oral antibiotic. And this is just a quick summary slide of how we classify the severity of acne. So it's quite important to be quite confident on being able to stratify the severity because this will be a classic presentation in general practice. So GPs will be managing this in primary care. And if it's severe, it would warrant referral to a dermatologist for consideration of a treatment like isoretinoin. So being confident with being able to describe the different things you see. So closed and open comedones and mild acne, and then moderate is where you start to see papules and pustules, and then you start to see cysts, essentially very large pustules, and evidence of scarring in very severe acne. And in terms of the treatment, the key things to be aware of is that you would start with topical treatments before moving on to oral ones, and you would never give an antibiotic on its own. You would always give it in combination with another treatment, either a topical retinoid or topical benzoyl peroxide, which is branded as adepalene. And if that doesn't work, you can move on to an oral antibiotic. Know to avoid tetracyclines in pregnancy. And the reason for that is because of the fact that it can cause dental discoloration in the newborn. And it's the same reason that we also avoid giving tetracyclines in children under the age of 12. And in both of those cohorts, in children and in pregnant, so you would use erythromycin instead. And remember, always co-prescribe that with a topical treatment to avoid the risk of antibiotic resistance if you use the antibiotic on its own. And you can also consider giving a combined oral contraceptive like cosaprindiol in females as well, because it's believed that one of the reasons that acne happens is because of increased sensitivity to androgens in the pilosebaceous unit, which is essentially the hair follicle and skin pore. And so by altering the ratio of estrogen to androgens with the contraceptive pill is quite an effective way of treating it, and also giving contraception if the female wants it. In severe acne, you would refer to dermatology, and then they would consider starting Roaccutane, which is oral isoretinoin, and that is strongly teratogenic. So obviously, if females are taking it, they'll need to be on adequate contraception, which would usually be more than just a barrier method. It would usually either be a contraceptive pill or an IUD or an IUS. And be aware of some of the key side effects of isoretinoin as well. So one of them being that it can cause very dry skin and lips and cheilitis, as well as deranged LFTs, and it can also cause depression and suicidal ideation. And so this is an important reminder that in any dermatological history, whether you're in an OSCE or in real life, always screen for mental health problems in any dermatological history, because it's a key component, because obviously a lot of the particularly quite severe skin conditions, acne, eczema, and psoriasis can often have quite a big mental health burden, and it's quite well recognized that particularly in acne, which affects teenagers, they're quite a group for this. So you always want to screen for that because they may benefit from some mental health support in that sense. So just move on to the next SBA. So 45-year-old woman with blushing, redness, prominent blood vessels, and numerous telangiectasias, but no comedones. So what's the likely diagnosis? You guys can just put it in the chat. Just quickly go through this as well. So the answer in this case is rosacea. So it's quite a clear diagnosis. What's useful here, just put there's some images here of some differential diagnoses for this kind of blushing and redness that you might see in this age group. So SLE can present like this, but what you would notice is that it spares the nasolabial fold, so that would be a butterfly-shaped rash. And in dermatomyositis, you can also get that kind of flushing and redness, but it's characteristically above the eyelids, which is called a heliotrope rash. And in rosacea, you can see those telangiectasias. So we'll just talk a bit about rosacea versus acne. So one of the clear clues is the age. So acne vulgaris typically affects adolescents and has comedones, whereas rosacea tends to affect people in the middle age, so 40 to 50 years old, and they have prominent telangiectasias and erythema, sort of like blushing and flushing. And it's usually the face in rosacea, but acne can affect the whole body, particularly the back and the chest. And this is an example of a late complication of untreated rosacea, which is a rhinophyma, which is essentially proliferation of the soft tissue of the nose, which can obviously be quite debilitating. So here we are with the next SBA. The new onset itchy erythematous rash on the elbows, knees, and abdomen with plaques, silvery scales, which bleed on gentle scratching. Also a smoker and drinks alcohol. Any ideas on what the most appropriate next management would be? So the diagnosis here is quite clearly chronic plaque psoriasis. And so the answer would be the first line management, which is emollient, a course of topical steroids, and a vitamin D analog, which is calcipotriol. And often that can be given in a combined treatment called Dovabet, which is the brand name. And then here's another case, which of the following medications may trigger exacerbations? Yeah, so the answer in this case would be lithium. So just a quick run through of psoriasis. So essentially psoriasis, the pathophysiology is not very well understood, but what we do understand is that there is increased epidermal proliferation of keratinocytes. And as they do that, as they proliferate, it causes the plaques, the characteristic silvery plaques, which you see typically on extensor surfaces, but they don't have to be. You can also get flexural psoriasis too. And so by extensor surfaces, that would usually mean the elbows, the knees, and the buttocks. It's a chronic condition, and often when you advise patients about the treatment, you will often say that we have to control the condition, but we can't really cure it. And one of the things we can do is reduce triggers. So some of the classic triggers for psoriasis is stress, as well as medications such as what the question said, lithium, antimalarials, beta blockers, NSAIDs as well. Also alcohol use can be a trigger, and smoking too. The plaques in psoriasis can exhibit what we call a Koebner phenomenon, which is where they can occur at sites of skin trauma. And when scratched, you can see the Auspitz sign, which is where there's pinpoint bleeding. Another thing to be aware of is that the different types of psoriasis. So this image in the center shows chronic plaque psoriasis, but you can also get guttate psoriasis, which is the classic teardrop lesions you see following a streptococcal infection. And also psoriasis can coexist with psoriatic arthropathy too. And you can also see nail changes, so oncholysis, pitting and ridging, and then obviously get characteristic joint pain as well. So the management is you'd start off with a potent topical steroid and vitamin D preparation, which you would apply at different times of the day. So you might apply the steroid in the morning and the vitamin D analog in the night. And you would only do that for no longer than 4 weeks and then you would review it before continuing it. Because obviously using topical steroids for long periods of times come with the side effects of skin thinning, telangiectasia, and it can increase susceptibility to secondary bacterial infection of the lesion because of the local immunosuppressive effect of the steroid. And very rarely it can also be systemically absorbed and cause adrenal suppression too. You can consider using phototherapy in psoriasis as well, so that might be either UVB phototherapy or they might do PUVA. So that's where they sensitize the skin with a drug called psoralen, and then they shine UVA phototherapy beams on it, and then that can help treat the psoriasis quite effectively. And then they can, if that fails, then they would consider systemic treatment. So methotrexate is useful if there's coexisting arthropathy, or they might consider cyclosporin or even biologics like adalimumab or ustekinumab as well. So this is the next SBA. 40-year-old man with itchy, greasy, flaky scaling. It's also HIV positive. So we treat this, so the case here is of seborrheic dermatitis, and we treat that with ketoconazole shampoo. And the reason why that's an effective treatment is because it's believed that the reason seborrheic dermatitis happens is because of an increased skin commensal called Malassezia furfur, which is a fungus essentially. So we can treat it with an antifungal shampoo. And this is a 2-month-old infant with scalp scaling, as you can see in the image. And how would we treat it? The answer in this case would be to use olive oil, which is and this image shows a characteristic cradle cap, which you see in seborrheic dermatitis. And in babies, because the skin is a bit more delicate, we would use olive oil rather than jumping straight to the antifungal shampoo. And this is just a summary of what I said. Some of the classic complications from seborrheic dermatitis is otitis externa and blepharitis, which is inflammation on the eyelid margin. And you can consider also treating with zinc pyrithione as well as the ketoconazole shampoo. And this is a slide just sort of summarizing eczema. So when we talk about eczema generally, we're just talking about dermatitis, but atopic dermatitis is specifically a type of eczema related to allergy, essentially. So it's the classic picture of someone who may have a history of asthma or food allergy or hay fever, and atopic dermatitis or eczema can be triggered by a variety of different allergens, and that could be that could be foods, it could be makeup products, it could be creams. So it can be quite difficult to tell what the triggers are, but often that's a key part of the management to avoid triggers and to break the itch scratch cycle. So they'll be feeling the need to itch, and then that breaks the skin barrier even further, which presupposes to more inflammation and more itching. So to break that cycle, we suggest that they use copious emollients. They use very short courses of topical steroids for the same reason that you don't want to use them too much in psoriasis as well, because of the side effects. And you can also consider using typically UVB radiation in eczema and systemic immunosuppression as well. And one of the key complications to know is the eczema lesions can be infected by herpes simplex virus, which causes eczema herpeticum, which is these monomorphic, punched out, rapidly progressive, painful rashes, which often need to be referred to, well, do need to be referred to hospital because they will need IV antivirals, potentially IV fluids, and obviously to be assessed by dermatology to confirm the diagnosis as well. So this is the next SPA. So red and raised lesions that are intensely pruritic, denies any unusual food or recent changes to the environment. He's recently started using ibuprofen, and that's the rash shown. So the answer in this case is urticaria, and this image is a characteristic picture of urticaria. So this red raised rash, and there's an obvious trigger in the case that he's recently started using ibuprofen, and drugs are a common cause of urticaria. So this slide just summarizes some of the key points about it. So it's often described as hives or wheals. So that's because there's edema under the layer of the skin, and so that's what's causing these raised, quite painful sometimes, and pruritic rashes. And the first line management for that would be a non-sedating antihistamine. And if it's refractory to that treatment, then you would then consider prescribing steroids. As a general rule, many dermatologists won't like using oral steroids or even topical steroids too much, because typically what happens in a lot of these skin conditions is that they will relapse once the steroid course is stopped, and often they can relapse and be even worse than when you started. So that's one of the reasons why they're not too keen to use steroids as a main form of control from a variety of different skin conditions. And these are just an image demonstrating the characteristic appearance of urticaria. And there are a number of different causes for urticaria, of course, number of different triggers. And sometimes it can be by infection or parasite, sometimes food or insect bites, and sometimes it can be as a representation of a systemic disease such as a vasculitis. And you can also just get chronic ordinary urticaria, which is usually idiopathic. So there may be a role for doing things like skin prick or blood radio allergen absorbent testing, which essentially will help confirm the specific trigger so that the patient can know to avoid that. And this is a good summary slide of the different potencies of topical steroids, which I haven't touched on yet. But yeah, this is a useful mnemonic to remember. So starting from mild to potent. Another one is like helps every budding dermatologist. This one's also quite a good one. It corresponds to the brand name then rather than the generic name. And in most cases, we would obviously start with low potency hydrocortisone, particularly on sensitive parts of the body, such as the face. And then we would work our way up to more potent steroids, depending on how the patient responds to treatment. But it's worth knowing which we would use for different parts of the body. So, for instance, in extensive psoriasis, you would use a potent steroid, such as clobetasone, or moderate potency. But in flexural psoriasis, so in the flexors, so the inside of the elbow, then you would use a mild steroid instead of a moderate one. So here we go. So this is evidence to the dermatology clinic with a darkly pigmented macule on the palmar side of his right index, 3 millimeters inside with poorly defined irregular borders. So the most likely diagnosis in this case would be acrolentiginous melanoma. And this picture shows a useful image of an example of that. And it's showing the Hutchinson nail sign, which is this pigmentation of the nail bed that you see. So acrolentiginous melanoma is a type of melanoma that particularly affects the fingertips. And you can get this characteristic sign, which is useful to be aware of. And some of the key points about a malignant melanoma to be aware of is how to assess. This is a tool that is used in general practice to assess the likelihood of a skin lesion being a malignant melanoma. And it's a very useful thing to be aware of, particularly for OSCEs and exams, when we might just show you an image and you can work your way through this. So a lesion that's asymmetrical, so this is a good example of a symmetrical, likely a benign nevus, whereas this is clearly asymmetrical. You'd look at the irregularity of the border, the colors. So if there are 2 or more colors within the lesion, that's quite suspicious for malignancy. If the diameter is larger than 6 millimeters, and if it's anything that's evolving over time, particularly something that's growing quite rapidly. And there's this concept of the ugly duckling sign, where if a patient has multiple moles and there's one mole that particularly stands out, that would be considered the ugly duckling and potentially quite concerning and warrants a referral. The most common and what accounts for 70% of most malignant melanomas is a type called superficial spreading. And then there's obviously a few other types as well, such as nodular, which is most aggressive, and acrolentiginous, which came up in the question. So I think another thing to be aware of with malignant melanoma is that so in any situation, you can warrant a 2-week referral. So whether you're in the GP practice or if you see a patient in A&E with a lesion like this, or you're in clinic for a different specialty, any clinician, even if you're an F1 or a consultant, can refer via the 2-week wait pathway. And let's move on to the next question. So this is a 60-year-old with a lesion on his ear for the past 6 weeks, gradually increased in size, and it's bled on one occasion, and he's had a renal transplant, which is a big clue. So the answer in this case would be a squamous cell carcinoma. And there are a few risk factors he has. He's immunosuppressed from his renal transplant, so he'd likely be on drugs such as cyclosporin or tacrolimus, which can increase the risk of squamous cell cancer. And he also has a history. Well, the location of the lesion on the ear is an area of the body which is high in sun exposure, so another risk factor. And the bleeding is characteristic of squamous cell cancer. So both squamous cell and basal cell carcinoma kind of grouped together as essentially the benign skin cancers. So they're mostly localized, but they can very rarely metastasize. And so there are also some precancerous lesions, which we'll touch on in the next slide. But some of the big clues which come up in exam questions to be aware of is excessive UV light exposure. So that's something you'd ask in the history. Immunosuppression, if they have a Fitzpatrick skin scale, which is either 1 or 2, which would signify fair colored skin. Margellans also refers specifically to a squamous cell cancer, which can develop in an area near the medial malleolus where there's chronic venous insufficiency, which leads to a venous ulcer that fails to heal properly. And then that can eventually lead to a squamous cell cancer, which you can call a marginal ulcer. And yeah, they're characteristically non-healing and they bleed easily. And these are 2 precancerous lesions to be aware of. I think this is my last slide. or one of my last slides. But these two, essentially, Bowen's disease is a squamous cell carcinoma in situ. So essentially, it's one that hasn't spread yet, essentially. So it's only within the layer of the skin. And actinic solar keratoses develop in areas of high sun exposure, such as the scalp. And they're characteristically these crusty lesions, which can very rarely, both of these can either progress to a full-on squamous cell cancer. And so when you see lesions that look like this, these need to be referred for consideration of an excisional biopsy and then, well, any kind of surveillance as well, if it is confirmed to be a cancer. So this is another lesion to be aware of. It's a bit of a miscellaneous thing. So keratoacanthoma, which can look quite similar to a squamous cell cancer. So often they are excised and then biopsied to confirm if it isn't that. And this is just a useful picture to be aware of, just so that you'll be able to diagnose it if it ever comes up. And then this is the last cancer to be aware of, which is a basal cell carcinoma. So some of the characteristic features of this are it'll be like a raised pearly nodule with telangiectasia and sometimes a central crater like this. And these tend to be very, very slow growing compared to squamous cell cancers. So that can be a big clue. And another thing to be aware of is when we excise these lesions, there will be usually an excision margin, which is usually about 2 millimeters. And in areas of the body where the excision might leave a scar, such as on the face, they may do a special kind of surgery called Mohs micrographic surgery, which is essentially a much longer process, but it removes the layers of skin piece by piece, which essentially leaves a much more smaller scar, but it's reserved only for lesions that are in cosmetically important areas, such as the face and the eyelids especially. But that's the end of my part, so I appreciate some feedback before I then hand over to Amar, who will take the second half of the session. Thank you so much.
Cool, thanks, Vishal. If you want to stop sharing, then I can start sharing mine, and then cool, cheers. Sorry, just give me a sec, I'm just getting out. Okay. Okay, I hope you can see that. Just gonna get to the slide that we were at. Okay, cool. So we're gonna start on the next part now. So again, it's gonna start off with an SBA. So a 22-year-old is admitted to the intensive care unit with an extensive blistering and necrotic skin rash affecting the whole body, including the mucous membranes. The patient was treated for an infection by her GP the previous week. What is the diagnosis? So the answer is toxic epidermal necrolysis. And next question is, which of the following is the most likely cause? And the answer to this is carmoxyclav. So this is because this is some dermatological emergencies that you should really know about. It's really important for your exam. So you have Stevens-Johnson syndrome versus toxic epidermal necrolysis. And so we'll go through each of them. So some common causes of which causes both of them are things like penicillin, anti-epileptics, especially like lamotrigine, which comes up a lot in exams, phenytoin, carbamazepine, also sulfonamides such as sulfasalazine, allopurinol, which is used in gout, and also like NSAIDs as well, and the combined oral contraceptive. So essentially, Stevens-Johnson is where your skin mucosa is affected by a drug reaction. So and you get this maculopapular rash with target lesions, and then these develop into vesicles or bullae. And you get something called Nikolsky's sign, which you'll see in again in other conditions, which I'll go into further on. But this is essentially a sign where you have blisters. So where you rub the skin just gently, you get blisters and erosions which appear. And toxic epidermal necrolysis is very similar. It's also Nikolsky sign positive, but this appearance of the rash is more scalded and is a lot more severe. So the difference here is that it covers more than 30% of the body compared to less than 10% in Stevens-Johnson syndrome. And but the management for both of these is that it's first of all supportive, because you can get things like fever, like systemic symptoms like fever, joint pain, tachycardia. But Stevens-Johnson syndrome is mainly supportive, but in toxic epidermal necrolysis, it's also things like IV immunoglobulins, and you can use things like cyclosporin and other immunosuppressants. Okay, so we're just going to cover a few other blistering diseases. So another SBA. So a 75-year-old woman presents with an itchy, blistering rash. Examination of her mouth is unremarkable. So what could this be? So the answer is bullous pemphigoid. And so we'll go into what bullous pemphigoid and pemphigus vulgaris both is, but the important thing here is that because there's no mucosal involvement, as that says in the vignette. Okay, so essentially, so pemphigoid versus pemphigus. So pemphigus has mucosal involvement, which is said. And the main thing is that what's caused by is autoantibodies against the intraepidermal proteins, usually seen in like middle-aged people, and you get blisters which rupture easily. And it's often fluid-filled blisters, and you also get that mucosal involvement, which I said. And as I talked about before, what Nikolsky's sign was, this one's positive. So the main investigation for this is you want to do biopsy for immunofluorescence. That can come up sometimes. And the main management is oral steroids. And also another thing to keep aware of is that secondary bacterial infections are quite common. So you want to give antibiotics as well, usually. But compare this to bullous pemphigoid, this is autoantibodies against the subepidermal proteins. Again, this usually affects more elderly people, and you get more tense and firm blisters compared to like the superficial ones in pemphigus. And the mucosa is again rarely involved, and this one's Nikolsky's negative. So the way I kind of remember the way to differentiate between the two is that pemphigus ends with an S, so you get superficial blisters, and then pemphigoid ends with a D, so these are more like deep blisters. And the management for pemphigoid is again so this one uses topical steroids and oral steroids, and of course refer to a dermatologist. And you can also use again doxycycline because this has anti-inflammatory properties. Okay. Okay, so another SBA. So a 40-year-old man presents with a 2-week history of an intensely itchy rash just below his knees and on his elbows. He states that the rash has responded poorly to an emollient cream. On examination, he has a symmetrical vesicular rash as shown. He also describes experiencing diarrhea and does not appear to be putting on weight. Given the most likely diagnosis, which of the following is the most appropriate management for this condition? I'm sorry if I'm not giving enough time to do the answers, but if you're watching this on recording, you can always pause it and come up with an answer yourself before we go into the answer. So the answer for this is a gluten-free diet, because this is actually celiac disease. So this is dermatitis herpetiformis, which we see in celiac disease because it says in the vignette that he has diarrhea, he's not putting on weight, so that kind of gives it away. And dermatitis herpetiformis is essentially an autoimmune condition. We get IgA deposits in the dermis, so you can see this itchy vesicular rash. And again, it's done diagnosis by the skin biopsy. And the management is, so you want to treat the underlying celiac disease, which is by gluten-free diet. We can also use dapsone, which is a sulfone, and this reduces inflammation and can reduce bacterial growth. It's something that's also used in leprosy as well. So, yeah. Okay, so there's some pediatric infections. So common rashes that you important for like GP and A&E that you might see. So the first one, we'll just go through each of them and what they are. So slap cheek is also known as erythema infectiosum, caused by parvovirus B19, which is what when you're especially worried about that, it might come up like a pregnant woman and her child has a slap cheek rash. So that often comes up in like SBAs. You got a roseola infantum, which is caused by human herpes virus 6, and you get this maculopapular rash, as you can see. But again, that's just supportive management for the child. Here you can see the strawberry tongue, and this is seen in Kawasaki disease and scarlet fever. So the way I remember scarlet fever is using a mnemonic called crash and burn. So you get conjunctivitis, a rash, cervical lymphadenopathy for the A, adenopathy, the strawberry tongue for the S, and you also get H is a heart condition, like heart problems, so you can get like myocarditis, and burn is like the fever, so that's what you get. Okay, and then EBV, so EBV, you can see this again rash, and this is often because a child might present unwell with like what might seem like a bacterial infection of the tonsils or something, but then they're given antibiotics by the GP. It's like the common question that comes up. They're given antibiotics, and then they usually get this rash because it's not actually a bacterial infection, it's EBV. And then you get like this maculopapular rash again. And here just conjunctivitis, which, like I said, you've seen Kawasaki, measles, and then adenovirus as well. Okay. Okay, so next question. So a 75-year-old bedridden man with advanced dementia presents with a 2-month history of intensely pruritic erythematous papules on his torso, groin, and extremities. He states that the pruritus is worse at night, and his medical history includes diabetes mellitus, hypertension, and dementia. Other residents at his nursing home have similar complaints, and which of the following is the best medication for his symptoms? And the answer for this is B, oral ivermectin. And we'll go into the reasons why. So this is scabies, and kind of gives you a clue as that this is something more because of the fact that other people in the home, it might mention that and be like, oh, other family members or people in the nursing home are also affected. And then they're also like bedridden, or they've been in bed for like a long time. So this caused by mites, that lay eggs and drop feces, and that can cause intense itching. And it's like this is a type 4 hypersensitivity reaction. So what you usually get is widespread intense itching, which is worse at night, and you get kind of these lines in between your fingers, and you might see it on these patients, and the excoriations because they've been itching so much. And where it's in an infant, you'll get they'll be itching their heads a lot, so that'll be where it's affected. So the management is permethrin, which is the same class as ivermectin, and then melatonin is second line. So there's some advice that is like quite important to give, and it usually comes up in like SBAs, like, oh, what further advice would you want to give for families? So post medication, so even after they've had a medication, the itching can last for 4 to 6 weeks. You want to avoid close physical contact with others until your treatment is complete, and close physical contact should be treated at the same time, even if asymptomatic. And all your beddings and clothings and stuff that you might have come in contact with should be well binned, get rid of. So the reason why we gave oral and not topical is because he's got the crusted scabies. So the topical can't really get in there. So this is usually seen in like immunosuppressed people, the malnourished and bedridden and elderly. And there you have very high number of eggs and fecal pellets on the scraping. So yeah, the topical permethrin won't work. You need to give oral ivermectin. Okay. And so tinea is fungal infection. So you kind of, it's called ringworm, but it's actually a fungus. So you kind of get this kind of target lesion almost. It's a raised edges, central clearing, annular rash. So it's sharply marginated, and you can get it on the scalp. So it's called capitis, corporis, which is your trunk and your legs and your arms, or pedis, which is your feet. And tinea pedis is also called athlete's foot. And this is again itchy. So I'll go through the management for this. So with tinea capitis, you want to treat with oral antifungals, so terbinafine, and also topical ketoconazole shampoo. And with tinea corporis, you want to use oral fluconazole. Yeah, that's what we want to use. Okay, so these are just leg ulcers. You guys have probably seen this and gone through this a lot, so I won't go through this too much. But so here you got the arterial. So we'll go through the venous one. So that's usually on the medial malleolus. That's what it's generally described as. It's shallow with flat margins. And so the way we treat this is with compression therapy, leg elevation, and in more severe cases, surgical management. And then here we got the arterial, which is more of you see more on the sole of your foot more times. It's like a punched out, because you see it on the pressure points, and this is more of a punched out and deep lesion, and you get like necrotic tissue in that. Sorry. And the treatment for this is actually revascularization surgery and antiplatelet medications to manage your risk factors. And you want to manage the risk factors like smoking and diabetes and things like that. And then again, you got neuropathic diabetic foot ulcer. Again, kind of that punched out lesion, and they don't act, there's no pain because they can't feel this because of that neuropathy. And you want to treat this by treating the underlying diabetes, so making sure that that's well under control. Make sure they're not putting pressure, so putting their foot up for rest. And you can also use topical growth factors. And then you got these pressure sores, which means that they have usually they're lying in bed. You see some patients post surgery and elderly patients who are just in bed all the time. So these kind of on the pressure points again, so like the sole of the heel. You can get this elsewhere, like on your buttocks, for example, as well. And this is you get atrophic skin and loss of muscle mass. And again, similar treatment to the diabetic foot ulcers. It's just an offloading of pressure, treating the wound, keeping it clean. Yeah, you can just pause it and read those. Yeah. Okay. Okay, so alopecia comes up quite a lot as well. So the main one to know about is the alopecia areata. That's the one that's very common. It's that autoimmune disease. You get that classic exclamation mark hairs, and you kind of get the patches in the patches of hair loss in the scalp. And it's usually people coming into GP kind of really worry about their hair loss, but it does reverse spontaneously. So they just need to be reassured that it will go away by itself. But there are some other types of alopecia you need to know about, but to be honest, they don't really come up that much. It's mainly alopecia areata. Okay, so the next one is next SBA is a 15-year-old boy attends a GP with a rash. He had a mild cold the last few days, but is otherwise well. On examination, there's a 2 centimeter discoid red patch on his left arm, which he mentioned started 3 days ago, and many smaller rashes on his back. Which of the following is the most appropriate next step in management? Okay, and for this one, it is E, to just reassure and discharge the patient. So this is because he has pityriasis rosacea. So this is like a classic SBA question. We get that initial rash, see in the question. So they have usually like a cold, have that initial discoid red patch, and then you get the it's like the herald patch because that's the first one, and then you get many other rashes appearing in this kind of a fir tree, Christmas tree pattern, as you can see in that picture. And it's just to reassure the patient because it's just self-limiting and disappears after about 6 to 12 weeks. But yeah, this comes up in questions a lot. Okay, so next question is a 50-year-old woman presents with severe, discrete, violaceous, polygonal, flat-topped papules and plaques with overlying white reticulated scales. She describes it as a persistent, intensely pruritic, cutaneous lesions on the flexor wrists and ankles. What is the most likely diagnosis? So answer this is lichen planus. So lichen planus is, you can remember, it's the 4 Ps for planus: pruritic, purple, polygonal papules. And usually in questions where it comes up, they do mention one of the 4 Ps, or here they're giving at least 3: polygonal, papules, plaques. So that immediately, all those Ps would draw you to the lichen planus. So it's unknown what this is. It's possibly autoimmune, but again, you get that purple pruritic papular polygonal, you get the Wickham striae, and you also get this white lace pattern, as you can see in that image there. It's like the in the mucosa of the mouth. And it's usually caused by drugs such as gold, quinine, and thiazides. And what you want to do is give a potent topical steroid. Give up if they have the white lace pattern in their mouth, then you want to give like an oral mouthwash, benzodiazepine. And if it's extensive, then you want to give oral steroids. And I think it's also worth mentioning lichen sclerosis, because obviously it's very easy to get confused between the two. And so this is essentially kind of similar, but you get on the vulva of elderly women. So that would be usually what will come up in the vignette. And you get atrophy of the epidermis. So they usually present with like dysuria and dyspareunia. And this is important because it's a risk factor for cancer. I think it's treated the same way as well, but check it. Okay, so yeah, this is vitiligo. Again, you probably all know this, but it's an autoimmune destruction of melanocytes. And so you get these well demarcated, depigmented patches. And because it's an autoimmune condition, you'll usually find it's associated with other autoimmune conditions. So type 1 diabetes, alopecia areata, as we said, IBD, pernicious anemia, lupus, those kind of things. So what you usually find in a SBA is like it will tell you that they have vitiligo already, and it will say they have other symptoms and what's the most likely diagnosis. So if they give vitiligo in a SBA, it usually means that the answer for the question is going to be a autoimmune condition. It's like a hint. Yeah. So the management doesn't really like a cure for this. It's mainly management because a lot of people have are kind of really self-aware about it and kind of have mental health problems because of it. So you want to get psychosocial support, which is really important. But you can stabilize it with oral steroids and UV phototherapy. Also use things like methotrexate and vitamin supplements. But yeah, regimentation, topical corticosteroids, vitamin D analogs. That doesn't really come up, to be honest, but it's mainly about the fact that it's related to these autoimmune conditions. Okay, again, really common, you'll see in GP a lot, like seborrheic keratosis. It's kind of this wart lesion stuck on. They usually, patients come in like, oh, I've had this for years. It's not growing. It's benign. So like Vishal went through like the skin cancers before, those are usually like fast growing, changing in color, bleeding, itchy. This isn't any of that. This is just a benign lesion, not fast growing. They've had it for years. So it's just reassure and don't need to do anything about this. And there's just other things they need to be aware about. Pyogenic granuloma. Usually the SBA will be like, oh, they had trauma to like their finger or something. And it's basically they get proliferation of capillary blood vessels, which causes this benign lesion. But this pyoderma gangrenosum is very much needs to be treated quickly. It's a very painful ulcer. And usually the question like they have ulcerative colitis. Or it could be rheumatoid arthritis, but they usually say it's ulcerative colitis. And the first line you want to give is oral steroids. So I think like really think about this inflammatory conditions, inflammatory rashes, steroids. Okay, and we'll just go through some of the erythemas that are kind of like just common and come up a lot. So just kind of go through them. So erythema migrans, it's that bullseye lesion seen in Lyme disease. Erythema infectiosum is what we talked about with the parvovirus, slap cheek rash. You got erythema ab igne, so that's basically it's overexposure to infrared, and it's so you usually see like a question where it's an older lady who sits by the fire a lot, or a person like a young woman who has period pain, so they use a hot water bottle a lot, and they find out they have this rash. It's because of that, and it's just reassurance, so to reassure them that it's nothing. And you got erythema marginatum. So this is actually in one of the major criteria to diagnose rheumatic fever, alongside polyarthritis, carditis, valvulitis, and like an evidence of a recent strep infection. So that this rash you see in rheumatic fever. Erythroderma is kind of confusing because I find it quite confusing, but essentially any rash that covers more than 95% of the body. So things like eczema, psoriasis, drugs, lymphoma, leukemia, or idiopathic even can cause erythroderma. But some key ones to know about are staphylococcal scalded skin syndrome, which is go look that up because it can come up too, and erythroderma psoriasis, and these can have acute deteriorations and be like emergencies in A&E. And then the last one is erythema nodosum. So again, you see that in things like pregnancy, tuberculosis, sarcoidosis, IBD, and I think strep pneumonia as well. So yeah, cool. So that's the end of my part, and that's the end of the tutorial. I really appreciate some feedback, guys. So but I hope you found it useful. Cheers. I'll stop sharing.